Next, we are going to discuss in oncosurgery one of the important topics, that is skin malignancies. We are going to discuss about skin malignancies in oncosurgery. Okay, so let's discuss about the skin malignancies one by one. One of the important topics for your exams, it may be asked in surgery as well as from dermatology. So whatever is there related to Bayesian law I am discussing here. So there are three skin cancers. In skin cancers, we have three cancers. They are basal cell cancer, squamous cell cancer, and malignant melanoma. Among this, which is most common and which is second common? So according to Bayesian law, the most common squamous cell cancer, second common squamous cell cancer. So first most common is basal cell cancer, second common squamous cell cancer, and which is having highest mortality is melanoma. Highest mortality is seen with malignant melanoma. So most common is basal cell cancer, second common is squamous cell cancer, the highest mortality is malignant melanoma. So now let us see the points from basal cell cancer, full of MCQs. Full of MCQs. Basal cell cancer is full of MCQs. So before going into the depth of basal cell cancer, let me tell you one important point from anatomy. So anatomically, if you see, this is epidermis. This is epidermis. I'm drawing very big. It is epidermis. Then comes dermis. This is dermis. So dermis is divided into papillary dermis like this, and reticular dermis is this. This is papillary dermis, and this is reticular dermis. And below is subcutaneous tissue. So skin is made up of epidermis and dermis. So epidermis is made up of how many layers? The mnemonic is cute looking girl Sangeeta Bijlani is the mnemonic for this. Cute looking girl Sangeeta Bijlani is the mnemonic for layers of epidermis. So stratum corneum, first layer is stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, stratum basalis are the layers. So cute looking girl Sangeeta Bijlani is the mnemonic. Please don't forget the mnemonic. Corneum, lucidum, granulosum, spinosum, basalis. And Sangeeta has many names. What are they? Malpighian layer. Spinosum has Malpighian layer or prickle cell layer. Prickle cell layer. The interesting point in this is squamous cell cancer arises from spinosum layer. Basal cell cancer arises from basalis layer. From basalis layer. So please remember, squamous cell cancer arises from stratum spinosum, basal cell cancer arises from stratum basalis, and usually melanoma arises from the epidermal dermal junction. From the junction between epidermis and dermis, there is melanoma seen arising from this place. Please don't forget this point. So spinosum, squamous cell cancer, basalis, basal cell cancer, and junction arises malignant melanoma. This is a high yield MCQ topic for you from anatomy. Okay, so the basal cell cancer, let us discuss in depth now. Basal cell cancer we discuss now. So it is most common in men. It is most common after 40 years age group. It is not common among young people. It is more common among after 40 years. And most common site is face. In the face, it is common along where? It is in the face along the tear flow area. It is common. Basal cell cancer is common in inner canthus of eye, nose, upper lips. It is common. So it is along the tear flow area. That is why it is also known as tear cancer. That is why known as tear cancer. It is seen along the tear flow area. That is why it is also known as tear cancer. Otherwise, it is common in face. In the face, it is common in this place, and it is most common in white-skinned people. It is most common in white-skinned people. And about the spread, you have to know very well about the spread of this cancer. Spread is very important in this. So it spreads by many modes. The various modes of cancer spread include direct spread, directly going to the adjacent area and spreading. It spreads by direct mode, or it spreads by lymph node spread, or it spreads by hematogenous meds. So these are the common modes of spread of any cancer. The basal cell cancer, the only route of spread is by direct spread, only by direct spread. It produces by eroding into the nearby skin. It produces rolled out edges. The ulcer is having a rolled out edge. So please remember, basal cell cancer has rolled out edge, and it slowly infiltrates into the adjacent layer only, and therefore it is also known as rodent ulcer, because it infiltrates the normal skin like a rodent. Therefore it is also known as rodent ulcer. Interesting point in basal cell cancer is there is no lymph node medicine. There is no lymph node medicine, and hematogenous meds is very rare in the sense it is less than 0.01%. The percentage is very less than 0.01%. This is the spread. So therefore, if you see basal cell cancer, the spread is only direct spread. The lymphatics are very thin. The basal cells cannot pass into it. Why it is not common in lymph node meds is because the lymphatics are very thin, and the basal cell malignant cells are very difficult to enter the lymphatics, which is very thin. Okay, please don't forget this. When you get an ulcer like this, basal cell cancer having an ulcer like this, you take this by wedge edge biopsy. We take wedge edge biopsy. The biopsy what you should take is wedge edge biopsy like this. Like this, you should take a biopsy. Wedge edge biopsy is taken. We should take a wedge edge biopsy, and the biopsy will show you the picture, classical picture, peripheral palisade arrangement of cells. This question can be expected as an image-based question. I will show you the image. Peripheral palisade pattern of cells. That is peripheral palisade pattern of cells seen on wedge edge biopsy. On a wedge edge biopsy, there is peripheral palisading of cells are present. And what are the predisposing factors? Who will get these cancers? Predisposed by UV light. Please remember, the skin cancers are mainly by UV light exposure, ultraviolet light exposure. That is why you can see the Western people are very much concerned about the sunlight, and always they put the sunlight cream, anti-UV light cream they will be putting, and this is the strongest predisposing factor. Sunlight is the strongest predisposing factor. Apart from this, they can also be seen in arsenic exposure, coal tar exposure, aromatic hydrocarbons. All these things can also cause basal cell cancer. But very important is sunlight. Sunlight is a very important predisposing factor for basal cell cancer. So coming to the types of basal cell cancer, there are two types of basal cell cancer. They are most commonly 90% of the time we get nodular type of basal cell cancer, also known as nodulocystic cancer. Nodular or nodulocystic. I will show you the image of nodular type of cancers, and very less, only 10% will develop this superficial spreading type. Superficial spreading type of basal cell cancer is only 10%. Only 10% will have superficial spreading type of basal cell cancer. The superficial spreading type is also known as field fire. It is also known as field fire type, because in this cancer, if you see, there will be peripheral lesions like this with a central clearance. That will be central clearing will be there. Central will be clear, and there will be peripherally there will be like a burnt farmhouse. There is a field house. You see a burnt field, what will happen? The central will be clear and the border will be burnt out. Like that, there will be a field fire appearance in superficial spreading type. And nodular type usually goes for ulceration. Ulceration is present. So they will go for ulceration. Nodular type, initially there will be nodular, very common in sun exposed areas, that will then go for ulceration. Superficial spreading type will look like a scaling appearance. They will have more scaling appearance. Please don't forget, they will have more of scaling appearance. And that scaling appearance give you a differential diagnosis like actinic keratosis. We can think it can be actinic keratosis or it can be an eczema. We can even sometimes miss the diagnosis thinking it is actinic keratosis or eczema in case of field fire superficial basal cell cancer. So please don't forget basal cell cancer type. So what are the clinical features? The clinical features is they present as a nodular lesion or ulcerative lesion along the medial canthus. That is why it is known as tear cancer. Please don't forget, it is commonly seen in this place. It is seen in this place. That is why it is known as tear cancer. It is exactly seen along this place. So it is exactly seen in this place, along the place where the tear flows. Therefore, it is in upper lip, medial side of the right side of nose, inner canthus, all these places you get this cancer. It is therefore known as tear cancer. Please don't forget, it is also known as tear cancer. So this is very important topic for exam, basal cell cancer. So more points are there for squamous cell cancer. Squamous cell cancer of skin. There are more points. Let us discuss about squamous cell cancer of skin now. Squamous cell cancer of skin is the second most common. It's the second most common cancer. Please remember, it is second most common cancer. It is also more common among males than females. From which layer squamous cell cancer arises? I told you from Sanghita layer known as spinosum or Malpighian layer or prickle cell layer. All these are same. Malpighian or prickle cell layer only this arises. So what are the pre-malignant conditions? Very, very important pre-malignant conditions you should know. There are so many pre-malignant conditions for squamous cell cancer. So many pre-malignant conditions are there for squamous cell cancer. They are number one, Bowen's disease. You should understand what is Bowen's disease and what is erythroplasia of Curette. Both are important MCQs for you. Erythroplasia of Curette. Bowen's disease is an in situ squamous cell cancer of skin. In situ squamous cell cancer of skin. Erythroplasia of Curette is in situ squamous cell cancer of glans penis. So in situ squamous cell cancer happening anywhere in the skin or in the shaft of penis. Shaft of penis is also known as Bowen's disease. In situ squamous cell cancer arising in the glans penis is known as erythroplasia of Curette. Other lesions are Paget's. Paget's disease can cause this. Leukoplakia can cause squamous cell cancer. Erythroplakia can cause. These are all pre-malignant lesions. These are all typical pre-malignant lesions. Yes, typical pre-malignant lesions. Senile keratosis. Senile keratosis. All these are typical pre-malignant lesions. First I will discuss you the lesions. The lesions causing squamous cell cancer. These are the various lesions causing squamous cell cancer. Factors, risk factors. What are the risk factors? Tell me the risk factors. Risk factors include very important radiotherapy. Radiation is one important risk factor. Long-standing ulcers. Can you tell me where you get squamous cell cancer in a long-standing ulcer? Like in venous ulcer or from a chronic scar, you can get Marjolin's ulcer. Marjolin's ulcer is also a type of squamous cell cancer. Marjolin's ulcer is a type of squamous cell cancer. Sunlight. Please remember, here also sunlight. Xeroderma pigmentosa. Xeroderma pigmentosa. I'm telling you what are the risk factors. Xeroderma pigmentosa. Lupus vulgaris. Lupus vulgaris. Human papilloma virus. HPV 5 and 16. Human papilloma virus 5 and 16. And very important is prolonged exposure to irritants. Irritations. Irritation of the skin, prolonged exposure to irritants can also cause squamous cell cancer. What are the prolonged irritation causes? They are classified as Kang cancer, Kangri cancer, and chimney sweeper cancer. Okay, chimney sweeper cancer. So from irritation due to long-term irritation can cause these problems. So Kangri is seen among Kashmir people keeping hard pot on the abdominal wall. So abdominal wall cancer is Kangri. Abdominal wall cancer is known as Kangri cancer. The Tibet guys know the Tibet guys will sit on a hard pot. Therefore in the buttocks they get a cancer known as Kang cancer. In the buttocks Kang, in the abdominal wall Kangri, in the scrotum is chimney sweeper. In the scrotum is chimney sweeper. So these are typically due to irritations causing cancers. So please don't forget irritation causing cancers. So irritations like sitting on a hot oven in buttocks, keeping a hot pot on the abdomen, Kangri in Kashmir, chimney sweepers getting in the scrotum is chimney sweeper cancer. Okay, so this is typical classical feature on examination of the ulcer. The ulcer will have this type of edge. What is this? Squamous cell cancer will have excavated edge. Excavated edge. Basal cell cancer has rolled out edge. Squamous cell cancer has excavated edge. It is more proliferative type of growth. It is a proliferative type of growth. It looks more proliferative. It can be looking ulcerative plus proliferative. It can be verrucous type. There is one more type looking on appearance, verrucous. I will show you the image, verrucous type. Among this type, verrucous type, we should not give radiotherapy. Radiotherapy is contraindicated. If you give radiotherapy for a verrucous type of squamous cell cancer, it will grow more. So therefore, how to diagnose this squamous cell cancer is the same method of biopsy. We have to take biopsy, and biopsy shows keratin pearl appearance. What is keratin pearl? Classical finding in squamous cell cancer is keratin pearl. Nothing but concentric of keratin is like this. It looks like a concentric appearance of keratin known as like an onion skin appearance. Like an onion skin, the epithelium appears like this. It is known as keratin pearl appearance. It is known as keratin pearl appearance is classically seen in squamous cell cancer, and this keratin pearl appearance is absent in which part of the squamous cell cancer? Like in esophagus squamous cell cancer, it is absent. It is absent in bladder squamous cell cancer. So please remember which all squamous cell cancer this keratin pearl is absent is esophagus squamous cell cancer, bladder squamous cell cancer, rapidly growing skin cancer. Rapidly growing skin cancer also this keratin pearl is absent. And with the presence of keratin pearl we have a grading system. What is the name of the grading? The grading system is known as Brodder's grading system. Brodder's grading system. So Brodder's grading system is present for these cancers. So Brodder's grading system is a grading for squamous cell cancer of skin. And there is a tumor marker. What is the tumor marker for squamous cell cancer? Yes, tumor marker can be asked for squamous cell cancer. Please don't forget it is cytokeratin 1/10, 1 and 10. Cytokeratin 1 and cytokeratin 10 are the two squamous cell cancer tumor markers. They are the two squamous cell cancer tumor markers. Please don't forget these points. Okay, so squamous cell cancer has two tumor markers. They are CK1 and CK10. And finally, when you come to the treatment of basal cell cancer as well as squamous cell cancer of skin, the treatment for both together is excision. Excision is a treatment, and the ideal margin given is 4 to 6 millimeter margin. The margin given for squamous cell cancer is and basal cell cancer is 4 to 6 millimeter margin on all sides. For lesions more than 2 centimeter size. Just 4 millimeter margin is enough for lesions less than 2 centimeter size. So these are all NCCN guidelines. So please remember, for lesions more than 2 centimeter, 4 to 6 millimeter. For less than 4 millimeter, it is just 2 centimeter or less margin is enough. So larger tumors, very big tumors, if you have this much size tumors, larger tumors, we can even give 1 centimeter margin will be given. So 1 centimeter margin can be needed for very large cancers, very large cancers. And nowadays, instead of in cosmetic areas like face, penis, fingertips, like cosmetic areas, now a new type of resection is done for skin cancers. That is known as Mohs micrographic surgery. That is known as Mohs micrographic surgery. That surgery is known as micrographic surgery, in which if there is a lesion like this on a skin, very important area of the skin, if there is a lesion like this, we have to cut serially, cutting number 1, cutting number 2, cutting number 3, each will be sent for frozen section. Each will be sent for frozen section one by one. Until that becomes negative, we should do serial resection of the, we have to shave the skin lesion until the margin becomes negative. This is specifically used for cosmetic areas like face, penis tips. So this is an important surgery, Mohs micrographic surgery done for both basal cell cancer as well as for squamous cell cancers. Other methods of treatment, we can apply 5-FU cream over the lesion, 5-fluorouracil cream can be applied. We can do cryosurgery. CO2 lasers can be used, and we can do radiotherapy also. Radiotherapy can also be done, or 5-FU cream, or we can do electrodissection using a diathermy we can remove it, or with a cryosurgery, or with a CO2 laser, or with a radiotherapy we remove it. So basal cell cancer, the only mode of spread is what I told you, only by direct spread. But squamous cell cancer has all modes of spread. It's spread by direct spread, lymph node spread, and hematogenous spread also. So squamous cell cancer has bad prognosis compared with basal cell cancer. It has bad prognosis. Please don't forget this point. Let me show you the images from skin cancers. So please remember, this is a classical MCQ for exam, peripheral palisading of cells. You can see how the cells are arranged peripherally like this. The lesion, the cells are arranged in a peripheral palisading pattern. This is a typical appearance in basal cell cancer. So this is a field fire. You can see the picture showing you is a field fire. In a superficial spreading type of basal cell cancer, you are seeing a field fire type of cancer. It is differential diagnosis, psoriasis, eczema, and keratosis. All these cases will have this field fire type appearance. So you have to take biopsy and confirm it. So it is usually common on trunk. So superficial type is usually common on trunk. Basal cell nodular type is common on face. So see this patient, nodular type. One of my patients with a typical lesion in the tear flow area. You can see the tear flow area. So you can see Bowen's disease in the skin, and this is erythroplasia of curate in the glans penis. Erythroplasia of curate in the glans penis. This is Bowen's disease in the skin anywhere else. In situ squamous cell cancer of skin is Bowen's, glans penis is erythroplasia of curate. You can see the typical keratin pearl formation, concentric rings of keratin. This is typical keratin pearl appearance, highly asked image-based question. So please see the Kangri cancer by keeping a hot pot on the abdominal wall, Kangri. You can see the chimney sweepers, scrotal cancer, the cancer in the scrotum chimney sweepers. And you can see a marginal ulcer from a long-standing burn scar, arising from a long-standing burn scar or any chronic scar. You can develop marginal ulcer. The interesting point in marginal ulcer is there is no lymph node enlargement. So I told you squamous cell cancers will have lymph node enlargement. Marginal ulcer is a cancer, there is no lymph node enlargement because the lymphatics will be obstructed by the previous inflammation. The lymphatics will be obstructed, so there won't be any lymph node enlargement. So see this verrucous cancer. This is verrucous cancer I told you. If you give radiotherapy, it will grow much bigger. Verrucous cancer, type of squamous cell cancer, radiotherapy is contraindicated. Okay, verrucous cancer, we have to do only surgery. This is a typical squamous cell cancer in the foot. We have to do massive resection. We have to do amputation for this type of patients, along with the lymph node dissection. So this is the Mohs micrographic surgery. You can see the Mohs micrographic surgery shown here. How you remove first thin layer, second thin layer, fourth layer, like that until you finally get that is margin negative. We have to keep going with the Mohs micrographic surgery. Okay. So please don't forget these two cancers: basal cell cancer and squamous cell cancers. Next we are going to malignant melanoma of the skin. One of the dangerous cancers. Very dangerous cancer is malignant melanoma of skin. We are going to discuss about malignant melanoma of skin. So very important topic for your exam. Among the 3 skin cancers, this is one high yield topic for your exams. Malignant melanoma is the high yield topic for your exam. So please concentrate on this. It is only 4% of the skin cancers. Please remember, it is only 4% of all the skin cancers. Luckily, the incidence is less, but 79% of skin cancer death is due to this. 79% of skin cancer death is due to melanoma. So that now you can understand the seriousness of this cancer. So 4% of all the skin cancers, but 79% of cancer death is due to this, and around 1.4% of cancer-related deaths. All cancer-related death, 1.4% is melanoma. So these are some interesting statistics. And in males, it is around 0.5 per 1 lakh population, whereas females, it is 0.2 per lakh population, per 1 lakh population. So if you can see, the males, it is incidence is more common than females. 0.5 per lakh population, and females it is 0.2 per lakh population. But it is very interesting point is the most common age group is 20 to 40 years. Very young age group. So very young age group. The most common age group is 20 to 40 years. And in this age group, females, in the 20 to 40 years females, if you see, the most common cause of death is due to this. So most common cause of cancer death, most common cause of cancer causing death in females in the age group of 20 to 40 years is melanoma. Please don't forget this basic point. This is a very basic point. So please don't forget malignant melanoma. These are the basic statistics taken from super specialty books. Just for completion, I'm telling you this. This is the most common cause of skin cancer death. Okay, please don't forget this. And in females, this is the most common cause of cancer related death in the age of 20 to 40 years. What are the risk factors? As usual, the risk factor is sunlight. Xeroderma pigmentosa. Family history is another risk factor. If there is a family history of melanoma, it is a risk factor. If there is a dysplastic nevus is 10% lifetime risk is there. 10% lifetime risk is there in dysplastic nevus. Please don't forget 10% lifetime risk. And immunocompromised patients, all immunocompromised patients. Immunocompromised cases. What are the immunocompromised cases means? Like HIV patients, patients on cyclosporine A, Hodgkin's lymphoma patients are the immunocompromised cases. You can get in these patients. In all these patients, you can see malignant melanoma. And please don't forget dysplastic nevus. It's a very classical mole seen in many people. It's 10 times lifetime risk is present in dysplastic nevus. Okay. When you see a malignant melanoma, what are the clinical features of malignant melanoma? If you see, this is a typical national board question. A, B, C, D, E. So this is a mnemonic. To see the classical clinical features of malignant melanoma, the mnemonic is A for asymmetry, B for border irregularity, So the border is irregular like this, border irregularity. C for color change, there is no single color, there are multiple colors inside the mole. Color variation, I will show you all the images. Diameter greater than 6 millimeter. D for diameter greater than 6 millimeter. See, such a big size, more than 6 millimeter. Or in fact, it is more than half centimeter. And the evolution, it is gradually evoluting. Evolution, it is gradually enlarging. Evolution, elevation, and enlargement, all are seen. Evolution, elevation, enlargement, and even we can add the F point. F is for funny looking. It looks funny, and F for funny looking. So A for asymmetry, border irregularity, color variation, diameter more than 6 millimeter, evolution, elevation, enlargement, and funny looking are the various features of malignant melanoma. These are the classical features of malignant melanoma. So now coming to the types of malignant melanoma. Very important for your exam discussion is this. So types of malignant melanoma. Okay. In this, I'm going to discuss you the various types one by one. Superficial spreading melanoma, SSM. Superficial spreading melanoma, number one. Superficial spreading melanoma, number one. Superficial spreading melanoma. Then nodular melanoma, number two. Acral lentiginous melanoma, number three. Acral lentiginous. Acral lentiginous melanoma, number three. Number four, lentigo maligna melanoma. Lentigo maligna melanoma. So in this, I'm going to discuss about these four first. I'm going to discuss the important points of this four first. So there are still more some types. I will discuss it later. Superficial spreading melanoma is the most common type. Please remember, it is the most common type, and it is most common among white people, among the white population, and usually arises from the dysplastic nevi. I told you there will be dysplastic nevi. A long-standing dysplastic nevi gives superficial spreading melanoma. This question is a NEET PG 2020 question. A long-standing superficial spreading melanoma will develop from a long-standing dysplastic nevi. A long-standing dysplastic nevi will give rise to superficial spreading melanoma. So the most common site is trunk in male. In extremities, especially lower legs in females. Lower legs or back in females, especially lower legs. So please don't forget, superficial spreading melanoma is most common in trunk in males, in lower limb in females. Okay, superficial spreading melanoma. Nodular melanoma is the second most common type. Please don't forget, the second most common type. It can happen anywhere, but most commonly it happens in head and neck. Head and neck is the most common site, followed by trunk. And it is most common in old age, 15 to 70 years. So it is not common in young age. For example, superficial spreading melanoma is common in little young age, in 20 to 40 years. But nodular melanoma is common in old age, 50 to 40 years. SSM is common in young age. Nodular melanoma is common in 50 to 70 years. The classical MCQ from nodular melanoma is the one. This is the mole which has more vertical spread rather than horizontal spread. There is more vertical spread. The more and more the vertical spread, there will be worst prognosis among all. Worst of all, guys, is nodular melanoma. It goes more deeper and deeper. Therefore, it is having worst prognosis. So acral lentiginous melanoma is seen among black people. Please don't forget, it is seen among black people. Even in black people, I used to tell in my classes, even in black people, it is common in white areas. What are the white areas? White areas like palms and soles. That's the MCQ. So the moles acral lentiginous melanoma is common among blacks, and in blacks also it is common among palm and soles. Palm and soles. Okay, it is common among palm and soles, and it is also having bad prognosis. It's also having a bad prognosis. It is also having a bad prognosis. Lentiga maligna melanoma. Lentiga maligna melanoma is also seen in old age. It is also seen in old age. It was previously known as Hutchinson's freckle. It is also known as old name Hutchinson's freckle. Is the old name of this. It is most common in face. Please don't forget, this is common in face. Lentigo maligna melanoma is common in face. It is most common in females, women than men. So usually remember, like lentigo maligna melanoma is common in old grandmas. It is common in old grandmas, and they have a typical Hutchinson freckle appearance. Hutchinson's freckle is also known as Hutchinson freckle. And old grandma, the lucky point is what? For old grandma, the lucky point is this is least common and least malignant. So it is very less common and it is least malignant. So least common, least malignant, and therefore it has good prognosis. So these are the points of lentigo maligna melanoma. So please don't forget these points. So the types of melanomas, the four important melanomas, I want you to remember. Superficial spreading type is very common. It is arising from long-standing dysplastic nevi. It is common in trunks in male, lower legs in females. Nodular melanoma is common in head and neck and trunk. Acral lentiginous melanoma common in palms and soles. Lentigo maligna melanoma common in face, in the face. And luckily, lentigo maligna melanoma is the least common type. Least common type. And there are some more types like subungual melanoma. What is this? Subungual. Subungual means below the nail bed. It is most common below nail bed. Many people think this is a hematoma and they even open it and let it out. And many times they will even resect it thinking it is a hematoma, and this will produce after a long time with the mets. So it's most common below the nail bed, and it will produce one sign known as Hutchinson sign. Hutchinson sign. What is this Hutchinson sign? This is a nail bed. If you see there is a melanoma below the nail bed, it will spread pigmentation to the nail bed like this. Pigmentation in the nail bed is known as Hutchinson sign. Pigmentation in nail bed is known as Hutchinson sign. Please don't forget this. The pigmentation in the nail bed is known as Hutchinson sign is seen in subungual melanoma. Another rare melanoma is amelanotic melanoma. Amelanotic melanoma is another melanoma. They have no pigmentation, so they present very late presentation because they have no pigment. They present very late because they look like a furuncle. People think there's nothing, just something else, and they don't come to hospital. Therefore, they have a late presentation. Amelanotic melanoma. So coming to the tumor markers of malignant melanoma. What are the tumor markers of malignant melanoma? It means Milan A, HMB45, and S100 are the three important tumor markers which we have already discussed. So the three tumor markers of malignant melanoma are Milan A, HMB45, S100 are the tumor markers of malignant melanoma. So now coming to the spread of melanoma. Malignant melanoma spread, very dangerous spread is there. It spreads by local spread. Please remember, it can spread by local method. It can spread by lymph node spread. It can spread by hematogenous spread. All methods of spread are seen. Hematogenous spread is also seen. So local spread, it can go from one place to adjacent place by a local invasion. The most dangerous spread is what? Vertical spread. Most dangerous is vertical spread. They grow vertically downwards. Which type has more vertical spread? It is nodular melanoma. That is why it is having the worst prognosis. It can produce local spread, either horizontally or vertically. Vertical spread is more common with nodular type. Please don't forget it. And lymph node spread, they spread through the lymphatics. For example, if a patient is having a mole in this place in the leg, they spread along the lymphatics like this. They go to the inguinal nodes, black. The nodes deposits will be black in color. As they are going along this lymphatics, we can see nodules all along the way. All along the way, we can see nodules. If the nodules are seen within 2 cm of the lesion, the main lesion, this is the main lesion. If you see a nodule within 2 cm of the lesion, what do you say it as? It is known as satellite lesion. If it is seen more than 2 centimeter from the primary, it is known as it should not be said as METs. It should be said as in-transit nodules. It is said as in-transit nodules. So within 2 centimeter along the lymphatic pathway is satellite nodule. More than 2 centimeter along the lymphatic pathway is in-transit nodule. Hematogenous, one of the important cancer producing heavy metastasis. It can produce METs to brain. It can produce METs to lungs. It can produce METs to liver. It can produce METs to small intestine. It can produce METs to other places in the skin. It can produce METs to bones. Extensive metastatic potential. Please remember, extensive metastatic potential, and that results in the most common cause of death. Most common cause of death in malignant melanoma is due to metastatic spread. It spreads everywhere and it causes death. So liver, lungs, brain, small intestines, other places in the skin, different places of skin, and bone, they can cause pathological fractures, etc. So therefore, if you see, the melanoma is one cancer which can spread by multiple methods. And coming to the prognostic factor of this melanoma, so how will you say the prognostic factor? The best prognostic factor is depth of infiltration. Please don't forget, depth of infiltration is the best prognostic factor. Ulceration of the melanoma is a bad prognosis. Lymph node positive is a bad prognosis. Satellite lesions and in-transit lesions are bad prognosis. Distant METs is bad prognosis. So all these are very bad prognosis. Among the prognostic factors is depth of infiltration, depth of invasion. So can you tell me which site has good prognosis? A comparative site, which site has good prognosis? Among the site, lower limb has best prognosis. Lower limb, best prognosis. And among the sex, which has best prognosis, male or female? Female has best prognosis. Among the type, which has best prognosis? Among the type, the best prognosis is with lentigo maligna melanoma, LMM has the best prognosis. So please don't forget what are all the best prognostic factors. So best prognosis is seen with lower limb melanoma, females, lentigo maligna melanoma. So worst prognostic factors are increased depth, presence of ulceration, presence of lymph node, presence of satellite nodules, and presence of distant METs all come under worst prognosis. So I told you the depth is most important. Therefore, we have classifications based on depth of infiltration. Classifications based on depth. They are Breslow's thickness. Breslow's thickness. Another is Clark's level, which level it has gone inside. Clark's level and Breslow's thickness are the two types of classification based on depth of infiltration. Breslow's thickness has 4 types. 1, 2, 3, 4 types. Only 4 types. The depth of infiltration is less than 0.75 millimeter. It is type 1. 0.75 to 1.5 millimeter. It is type 2. It is Breslow's type 2. 1.5 to 4 millimeter. Here you should understand. It is 1.4 to 4. If it is more than 4 millimeter, it is Breslow's 4. So please remember 4 for 4. More than 4 is 4. When you come to Clark's level of invasion, Clark's level of invasion is 5 level. 1, 2, 3, 4, 5. There are 5 levels in Clark's. One, nothing to mark up in this. Just epidermis is 1. Only going up to epidermis is 1. Going up to the papillary dermis is 2. Going up to the papillary dermis is 2 and reticular dermis is 4. Please remember reticular dermis is 4. So then what happened to 3? 3 is the junction between papillary dermis and reticular dermis. So junction between the papillary dermis and reticular dermis is 4. Sorry, 3 and 5 is subcutaneous. It goes to the subcutaneous. So very simple. So Breslow's classification and Clark's classification. Breslow's is 4 numbers. Please remember Breslow's is 4 numbers. Clark's is 5 numbers. 1, 2, 3, 4, 5. Breslow only 1, 2, 3, 4. 0.75, 0.75 to 1.5, 1.5 to 4. More than 4 is 4. And 3 is junction. 3 remember 3 is a junction in Clark's level of invasion. Please don't forget this point. And when you come to management of melanoma, management of malignant melanoma. So management of malignant melanoma, you should understand, we have to excise the mole completely. Excision is a treatment of choice. Excision, we have to excise it with a wide margin. And if there is no involvement, we have to look for sentinel node biopsy. Was also done in those days. If there is a lower limb, we can even check for sentinel node and confirm whether it is present or not. If sentinel node is positive, we go for block dissection. If sentinel nodes are positive, excision of the primary, sentinel node biopsy is also included. And after excising the mole, we reconstruct that place. After excising it, reconstruction is also done. So excision I will discuss separately, but one important thing I want to tell you here. For example, a patient is having a mole in the lower limb like this. Patient is having a mole here in the lower limb, and all along the way there are in-transit nodules. What therapy can be given for this patient? For this patient, I can isolate the femoral artery or external iliac artery and isolate the external iliac vein or femoral vein, and I will give chemotherapy through the artery like this. Through the artery, if I give chemotherapy, it will go and act only in this lower limb, and as it is coming out of the veins, we will remove this blood alone separately. So this therapy is known as isolated limb perfusion therapy. Isolated limb hyperthermic therapy. Hyperthermic infusion of chemotherapy. So isolated limb hyperthermic infusion of chemotherapy is this. And the question is, in this isolated limb hyperthermic chemotherapy, what is the commonly used drug? The commonly used drug is melphalan. Melphalan is used in this hyperthermic infusion. So this is one of the treatment for limb melanomas with in-transit satellite nodules. We can use isolated limb hyperthermic therapy. So coming to the excision margin from latest NCCN guidelines. Excision margin for patients. If the lesion is 0 to 1 millimeter thick, 1 to 2 millimeter thick, 2 to 4 millimeter thick, or more than 4 millimeter thick, let us have the margins now. The margins according to NCCN guidelines. So 0 to 1 millimeter tumors will need 1 centimeter margin. 1 centimeter margin. 1 to 2 will need 1 to 2 centimeter margin. 2 to 4 millimeter or more than 4 millimeter patients, we should have 2 centimeter margin at least 2 centimeter margin. So please remember, so the margin needed for malignant melanoma are 0 to 1 millimeter depth. This is not breadth, it is on depth. Depth is 0 to 1 millimeter. Give 1 centimeter margin on all dimensions. 1 to 2 millimeter, 1 to 2. 2 millimeter or more, we should give 2 centimeter margin. At least 2 centimeter margin should be given for malignant melanomas. This is from latest NCCN guidelines, so please don't forget these points. So let us see the pictures now. This is a typical dysplastic nevi. You can see the dysplastic nevi, typical pre-malignant. This goes on long-standing to superficial spreading melanoma in 10% of the patients. So 10% of them will go for superficial spreading melanoma. So what are the features of melanoma? They will be asymmetrical. A for asymmetrical, B for border irregularity. You can see the border irregularity. C for color variation. D for diameter more than 6 millimeter. E for evolution, elevation. And malignant melanoma can look all these features. All these are melanoma features. All these are melanoma. Superficial spreading melanoma. You can see the nodular melanoma. You can see a subungual melanoma. You can see a superficial spreading melanoma. Subungual melanoma. Sorry, acral lentiginous melanoma. Typical palm and soles. Acral lentiginous melanoma. and you can see a picture showing you a typical subungual melanoma with Hutchinson sign positive. This is typical Hutchinson sign positive in this. So these are the pictures I collected from my oncocytic friends. They gave me these pictures, and this is a superficial spreading melanoma in the face in a very old grandma. Superficial spread. So this is a lentigo maligna melanoma, LMM, in an old grandma in the face, because lentigo maligna melanoma is common in the face in grandmas. Remember it, in grandmas it is common in the face. So this is an acral lentiginous melanoma. So satellite type nodules, you can see various melanomas. So many melanomas are there. So superficial spreading melanoma is most common. Acral lentiginous is common in dark skin people. Nodular melanoma carries worst prognosis. Lentigo maligna melanoma carries the best prognosis. So all the other points we have discussed about the melanoma. So this is a picture showing you a melanotic melanoma. See, the lesion is not at all having any pigment and we will miss the diagnosis. You will miss it and they come very late with the metastasis. It is also having a bad prognosis. A melanotic melanoma also has a bad prognosis. Please don't forget this point. So please don't forget that Breslow's thickness and Clark's level of invasion. There are two types of classification. Breslow's 4 types, Clark's 5 types. Okay, so we have to do treatment. So this is a typical mole here, melanoma here, which is having within 5 cm is so within 2 cm is known as satellite nodules. More than 2 cm is known as in transit nodules. So please don't forget within 2 cm is in transit nodules. Okay, this is typical picture showing you the satellite nodules and in transit nodules. In transit nodules and satellite nodules are mentioned in this picture. So please don't forget this. So treatment is excision. The margins I already told you. The margins more than 2 mm depth. We should give at least 2 cm margin excision. So please don't forget this case typically needs isolated limb perfusion therapy. This case will need isolated limb perfusion therapy with a melphalan. This can need melphalan. Isolated limb perfusion therapy with a melphalan is needed for these cases. Okay. So that completes the typical malignant melanoma. So please don't forget these two skin cancers are very important. Squamous cell cancer, malignant melanoma, and basal cell cancers. Thank you.